From the nation's capital in Washington, D.C., the Congressional Report, with your host, Iowa Congressman Latham.
This country is based on farms, on small businesses, and creating jobs and opportunities. That is the lifeblood of this nation.
And now your host, Congressman Latham.
Welcome to the Congressional Report, and thank you for joining me today. To put it plainly, our healthcare system is plagued by inefficiency, rising costs, and the inability of millions of Americans to find affordable health insurance. Improving healthcare must rank among our most pressing concerns as we begin to chart a course back to prosperity. A nationwide nursing shortage is also squeezing the American healthcare system, and the growing shortage of qualified nurses is threatening to become even more severe in the years ahead. To keep that from happening, I've introduced legislation that would create a loan repayment program for nurses who agree to become nursing instructors after they earn advanced degrees. This incentive will encourage more nurses to become faculty at nursing schools and increase their capacity to teach and train more nurses. If we want the kind of accessible, affordable, and patient-centered health care that Americans deserve, we must make a renewed commitment to our nurses. Joining me on this edition of the Congressional Report is Dr. Vernell DeWitty, a program director for the American Association of College of Nurses. Well, welcome, Doctor, to the Congressional Report. It's a real pleasure to have you with us today. And tell us a little bit about yourself and your organization.
It's a pleasure to be with you this morning. I serve with the American Association of Colleges of Nursing in the capacity of a deputy director for what we call the New Careers in Nursing Scholarship Fund. It is a program that's been funded by the Robert Wood Johnson Foundation to increase the number of underrepresented groups in nursing and to increase the size of the nursing workforce.
What do you see as the biggest problem facing nurses today, or the shortage of nurses? Do you have numbers on this?
Yes, it's been projected that by the year 2016 we will need an additional 1 million nurses, and that comes from the U.S. Bureau of Labor Statistics. We face a shortage of nurses for several reasons. Number one, we have an aging workforce. Number two, we have an insufficient supply of nurses. And that insufficient supply is created by our inability to educate enough nurses because of the lack of faculty positions in schools of nursing. We turn away almost 50,000 applicants who are qualified to attend nursing school simply because the schools of nursing are not able to take those students into enrollment.
And that's a real problem. I know we've identified in Iowa. I think currently we're about 2,000 nurses short in the state. In less than 10 years, I expect that to go up to well over 10,000 shortage. And I did a series of meetings last year with nurses over at the University of Iowa, with the College of Nursing over there, and a lot of the community colleges. And they identified the shortage as far as faculty, and that's really where you come in. So what do we need to do to have more faculty?
Well, there are several things that we need to do. First of all, we need to make it attractive for nurses to elect to become faculty members. One of the real constraints is the amount of time it takes for most nurses when they decide if they want to be a faculty member to complete their degrees. And part of that has to do with lack of funding. Another part of it has to do with the discrepancy between salaries for nurses in academia and those who work in the service side.
How much is the difference in pay between a full-time RN and the faculty?
Well, you hear different numbers, but the projections are anywhere from about $10,000 to $15,000 in terms of a difference in pay between the two ranks.
So you actually get paid considerably less
to work in academia.
In academia.
Yes.
So how do we address that? What would be the incentive for a practicing RN today to be, go on and get an advanced degree and take a pay cut?
Well, one of the things, of course, is to look at how you might increase the salary line for nursing faculty. Another is to make it affordable for nurses to go back to school and to complete their doctorate or master degrees. And I think if you approach it in both sides, then you'll have more nurses willing to go into academia.
I know one concern that was presented in my meetings across the state was that an RN today, if they wanted to become faculty or go into academia, they can't continue to work and get stipends basically to get an advanced degree. They'll lose they have to either go full-time or not go at all as far as the colleges, and that's something that we've tried to address here.
Yes.
But how big a roadblock is that?
I think it's a considerable roadblock because when you consider the age of nurses when they go back to complete their degrees, which is considerably later than other professions, they have full-time commitments to home, to family, and they have to consider that as they, continue their degrees. For example, when I completed my doctorate degree, I worked full-time, so it took me 6 years to complete the degree because it was necessary for me to work during that time period. And I'm sure that my situation is very typical for most nurses, so that if there's a way to go to school, focus in on the study, and have that financial commitment satisfied, I think you will have a greater increase in the number of persons who choose to do that.
I know the nurses do such a great job out there with the patients. They treat not only the medical problems, but the patient themselves and the patient's family. Oftentimes, that's the face of healthcare, is in the nursing profession. And oftentimes, the nurses are maybe the primary breadwinner in their family, certainly, and probably in some cases, just as importantly, provide the benefits as far as health insurance and things like that for their family. So it's very difficult for them to quit and go full-time to university. I've introduced legislation to address this. I don't know if you wanted to give a critique about that or what.
Yeah, I've been informed about the bill that you've introduced, and I think that you're to be commended for doing that. I think what it does is it positions the profession in such a way that we will really be able to attack the problem of nurse faculty by offering a loan repayment option for those persons who choose to go back and complete their doctorate degree in the amount of full 100% loan repayment. Then I think it becomes very, very attractive for nurses to do that and then to become members of academia. And I think focusing in on the master level nurse and the doctorate nurse is really where we want to go if we want to impact the pipeline for nurses in the future. Some of the kind of preparation in the Title VIII is limited, and I think there's wide distribution of that, and we need all nurses to come into our profession. But to focus, as your bill does, on the increasing the academia side and persons to prepare more nurses is, I think, outstanding.
Yeah. Well, the thing that I learned was that from all my hearings around the state was that we're turning away about 1 out of 3 qualified applicants to nursing school today, and it's not because they don't have the physical buildings or the ability to take them in, but there just aren't enough of the faculty to teach them.
Yeah, that's right.
And that's a real roadblock, obviously. The bill I've introduced is bipartisan. I don't know, what do you see as far as the overall health care reform, and how important is this as far as one part of that?
When I think about what's going on in our country as it relates to health care reform, I like to frame it within the context of what we call the Iron Triangle, which talks about access, quality, and cost. And I think nursing is very pivotal to each one of those prongs. When you think about access to care, if you don't have a sufficient supply of healthcare providers, then it doesn't matter if someone is paid for it, you won't be able to receive the care. And when it comes to quality, of course, as you've indicated, nurses are at the forefront of being with patients in many healthcare environments and settings, providing that care, and they're there all the time. And then when it comes to cost, having quality care can reduce medical errors. The evidence shows us that having a more highly prepared staff with more professional nurses really does reduce the cost of care, and also nurses in advanced practice role are able to provide primary care in situations where maybe physicians may not want to do that or be interested in primary care. So I think that when you look at access, cost, and quality, nursing is at the center of all of those.
Mm-hmm. Well, what do you see as in the overall reform of the health care problem that we have today? What would you like to see as far as regarding nurses? What would be the most important thing for you?
First of all, I think recognizing some of those advanced practice roles for nursing, where nursing is able to adequately provide primary care, nurses being involved in some of the prevention aspects, because for a very long time we've tended to look at treatment, and we've never focused much on prevention. And I think that's a position and that's a role that nurses are well prepared and have been doing it, but in a very limited scope. So I think that, and of course having nursing at the table as we begin to look at reform, I think you have a care provider who really does understand what happens at the point of care for patients.
What do you see as far as level of support for reforming, as far as the nurses faculty? This is the bill I have is bipartisan. We introduced it last year. Tammy Baldwin from Wisconsin is my lead co-sponsor of the bill. But are you going to be working with other organizations or trying to push forward this agenda?
Yes, well, at AACN, we have always collaborated with other nursing organizations to really be supportive of those kinds of legislative measures that we think will advance nursing, provide an ample supply of nursing, educate nursing faculty. So I am sure that our legislative arm will be working with other nursing organizations such as the American Nurses Association and other nursing groups to collaborate and to provide real support to help the bill to advance.
Very good. Well, I appreciate all that help, that's for sure, because that's how things get done around here. But we have nursing education today. There's the universities, like the University of Iowa. You have private colleges and you have community colleges. Is there any real difference in the roles between the different types of schools, or what do you see in that regard? Yeah.
First, I think that there's a need for different pathways for persons to become nurses. Some nurses, some persons choose to attend community colleges, and I think that's a good entry point for some people, and we hope that those persons move from the associate degree level to the baccalaureate level, the master level. I think that there's a different career path for many nurses, and I think what needs to be available are opportunities for persons to enter the profession and then to progress according to their own career goals and objectives. Everyone may not have the desire to become a PhD academia person. We need strong nurses at the bedside. And I think that we need as many opportunities as well as pathways for progression that we can come up with for nurses. So there's a place, I think, for all of us.
Well, great. Well, I appreciate you being with me today, and keep up the great work. We've got a lot of challenges ahead, but anyway, thank you so much.
Thank you so very much.
You bet.
Sure.
Thank you. Continuing our health care discussion, I'd now like to introduce Robert Moffett, Director of Health Policy Studies at the Heritage Foundation, to discuss the ongoing health care debate. Anyway, thank you very much for being with us today.
I'm very happy to be here, Congressman.
Yeah.
Yes.
Tell us a little bit about yourself, first of all, and the Heritage Foundation.
Sure.
What do you guys do?
Well, I'm the director of the Center for Health Policy Studies at the Heritage Foundation, and I served before that in the Reagan administration for 8 years. I was the former Principal Deputy Assistant Secretary for Legislation at the Department of Health and Human Services, where we had enormous responsibility for health care, in particular the Medicare and the Medicaid program. The Heritage Foundation is a nonpartisan think tank. We're kind of an idea factory. We do studies and reports and analysis of various issues, including health, education, welfare, housing, urban policy, taxes, budget, regulation, international foreign policy, international trade and defense. So we sort of cover the waterfront on health and various other types of policies and present testimony before Congress periodically.
To health care. Sure. What do you see as the biggest challenges we're facing as far as this whole debate?
The biggest challenge we have right now is to make sure that we get good value for our health care dollars. We are spending, as you know, close to $1 out of every $6 in our wallets on health care. The Congressional Budget Office that works for Congress, as you know, they're projecting very high health care increases in the next few years. With the retirement of the baby boom generation, we're going to have 77 million people start to entering the Medicare program. And Congressman, that is going to be a demand for medical services that the world has never seen. So we're going to be spending a lot of money. Now, I personally do not think the fact that we spend a lot on health care in and of itself is a problem. I think the problem is that we are not necessarily getting value for our money in terms of the health care financing and delivery. We are getting terrific value when it comes to medical research and science and technology. We have 87 Nobel Prize winners since the inception of the Nobel Prize in medicine. We outclass every other country in the world in terms of medical quality and medical technology and medical breakthroughs. Where we have a problem, though, is in the healthcare financing and the delivery system related to our health insurance markets, not only in the government. The government programs are, in fact, inferior in many ways, but also even in the private sector, and we have to fix that.
When you talk about value, what do you suggest that we do to get value for our dollars in the health care? I mean, what are the answers?
That's an excellent question, because it's the question now that occupies Congress and the White House. In my view, we are never going to get value for health care dollars unless the people who actually pay the bills control the dollars. Health care costs are paid 100% by individuals and families, not employers, not the government. 100% of health care costs are paid by American households. The short answer to your question
now, most people would say, well, I get my health insurance at work, and so I don't pay for it.
Well, that's not true.
Explain that.
I'll be very happy to explain it. A lot of people do think that their employer's contribution to their health care benefits package is the employer's money. In fact, it's not. There's no economist in the world who thinks that that's the employer's money. Every dollar in your health care benefits package is a reduction in your wages or other compensation. You pay for your health care. He spends your dollars. The problem is sometimes he'll spend your dollars on a health plan that you don't like. You may be in favor of a certain type of health care plan with certain types of benefits, but his concern is primarily cost. So you have this kind of conflict between labor and management in most cases on health policy, and it's understandable. My view is that what we have to do is we have to make sure that individuals and families control the dollars. How do we do that? The first thing we do is we say to you, in effect, that if you do not or cannot get health insurance through the place of work, and many of your small businesses do not offer health insurance, you give people at least the same tax breaks that people get if they get health insurance through the place of work. You and I, when we get health insurance through the employer, we get unlimited tax breaks, and that's terrific. It's great for you and I. But if we work for a company that does not offer health insurance and we have to buy health insurance on our own, we have a tax penalty imposed on us that could raise the cost of that health care benefits package anywhere between 30 to 40 or to 50%. for the same package of benefits.
You're saying you're paying for that with after-tax
dollars
rather than pre-tax at companies.
Which makes it, I mean, most Americans don't understand the size of this. This has an enormous influence on the cost of health care. And if you try to do it on your own with after-tax dollars, you could be paying, as I said, 50% more for the same package of benefits you would have gotten at the place of work. Now, that's unfair. That is profoundly unfair. And it's one of the reasons why we have to fix the insurance markets. But you cannot fix the insurance markets unless you create some equity in the tax code. I'm not saying that we have to spend a fortune on the uninsured. What I am saying is the least we can do is to say, we are not, members of Congress, we're not going to penalize you simply because you can't get health insurance through the place of work. There are a lot of ways to do it. My colleagues at the Heritage Foundation have developed a number of options, including tax credits, subsidies for low-income people who cannot afford health insurance. But if you do not do this, you are not going to have a functioning health insurance market. And that is the key financial problem in the American healthcare system. It's the genetic flaw. If we were to fix this, we would have a much more rational spending in healthcare. Doctors and hospitals and plans would be forced to compete directly for consumers' dollars, just like they do in every other sector of the economy. And then you are talking about increasing value to the patients, increasing value to individuals and families as consumers, and increasing the productivity of the healthcare economy, meaning that we're going to get the same kind of value from health insurance that we get from research and development in our healthcare system. We can do this. This is very, very doable, but we have to focus on what's broken, not what's fixed.
Right. You know, the big debate, and the administration now is talking about a top priority where it is on the list with the economic situation we're going through. No one knows for sure right now, I think, but a big thing that's been pushing this is the 47 millions of Americans who do not have health insurance or coverage.
Right.
Could you break that down? Who are these people?
Oh, we know a lot. Oh, let me tell you, Congressman, we know a lot about the uninsured. We have studied the uninsured to death. We can count the hairs on their head. We know where they live. The number has been roughly 46, 47 million. That's a snapshot of the uninsured population by the Census Bureau. It is not a persistent group of people. Actually, it's a very, very diverse and dynamic group of people. People are not chronically uninsured over a long period of time. If you look at the professional literature on this, as we have at the Heritage Foundation, what you find is the overwhelming majority of people who are uninsured are people who had coverage, but they lost it. They lost it because of a change in their life condition.
To be considered uninsured, do they have to be uninsured for a year? Or is it one day out of the year?
Well, actually, it's a spell of insurance, and it varies. Most of the people who are uninsured on an annual basis are uninsured for like 5 or 6 months.
Okay.
Most of them, about 50% roughly. Others are uninsured longer. What seems to be happening is people lose their jobs or they change their jobs and they lose their coverage. That's basically what happens. There was a study done a few years ago by a couple of professors from Penn State University, and they looked at the uninsured over a long period of time, a 4-year study. And then, over 4 years, you're talking about roughly 80-some million people who had lost their health insurance coverage. What they found was that only 12% of that entire population were chronically uninsured. The overwhelming majority of them were people who had health insurance but lost it. And they lost it primarily because of a job change. The problem is most acute among employees who work for small businesses.
Well, that was my point. And I was full of small businesses.
Right.
And that's,
which means,
how can we address that?
Oh, yes. I mean, there are a lot of ways to do it. As I said, I think the most important thing to do is to give people tax relief or subsidies, frankly, for low-income people who cannot afford to pay taxes, to give people tax relief regardless of where they work for the purchase of health insurance. In other words, equalize the tax code. That really does change things dramatically, because what you do is you tie the tax break and the insurance to the individual, not just the job. You can leave private health insurance with the employer alone. You don't have to touch it. But the point is, you allow people to get tax relief outside of the place of work as well. To the extent to which people actually own their own health insurance policies outside of the place of work, just like they own their life insurance, auto insurance, homeowners insurance, any other type of insurance, they can keep their insurance from job to job without a tax or regulatory penalty. Congressman, if we were able to establish portability in the coverage of health insurance and stabilize the health insurance market, we would have a dramatic reduction in the number of people who are uninsured, even if we didn't spend one extra dime on health care. We know why people are uninsured. It's not that they don't have access to it, they can't keep it once they've got it. So we've got to establish portability and personal ownership of coverage. If we start to do that, then these numbers of the uninsured will start to come down. You'll stabilize the market, but even better, insurance companies then would be competing more effectively and more efficiently to cover people, which is what they should be doing.
We could talk about this all day, but
and I'd love to do it. We can get together.
We've only got about a little over a minute. But if you were to list 1, 2, 3, 4, whatever things that need to be done to reform in a minute here, what would you do? One is to establish equity in the tax treatment of health insurance. We should make sure that our tax policies and government subsidies are fair. They're targeted to the people who need help. In the case of health insurance, it is mostly employees who work for small businesses. That's number one. Number two, establish policies that will promote portability in health insurance. That is to say, you should be able to keep your health insurance just like you keep your life insurance or auto insurance or any other type of insurance, and be able to take it with you from job to job or through life's changes. People change. Young people have different needs than older people. As you go through life, your health insurance policy should be able to change with you, just like other policies do. And finally, I think we have to start to reform our federal entitlement programs. We are, as you know, we're faced with big challenges when the baby boomers start to retire. We have got to put changes in place now so that our grandchildren, our children, are not going to be burdened with mountains of debt, either savage increases or cuts in benefits, savage tax increases or cuts in benefits for ourselves and our families. Very good. Well, I appreciate very much you being with me today. It's a pleasure. Like I said, we could talk for a long time. So
yes,
thank you so much.
Very good seeing you.
Our healthcare system faces grave challenges, including a nursing shortage that's already taken root and has the potential to explode over the next few years. But there's some good news. The President and members of Congress on both sides of the aisle have indicated a willingness to leave behind the political squabbling of the past to do what's right for the American people. There are a number of innovative ideas ready and waiting for Congress to do the legwork and find a way forward, including my legislation to address the nursing shortage. We put this off far too long. It's time to act in a bipartisan way to strengthen American health care. If you'd like to learn more about the health care debate or my legislation to address the nursing shortage, please give a visit to my website, www.latham.house.gov. Once again, I want to thank my guests for their insights into one of the most pressing challenges facing our country, and I hope you'll join me next time on the Congressional Report.
From the nation's capital in Washington, D.C., this has been the Congressional Report with Iowa Congressman Tom Latham. Have a question, comment, or concern? Congressman Latham wants to hear from you.